Chris Rogers and I have been talking about this for a long time, and it always comes down to the basics.
Sure.
Right? Have good sleep, eat your fruits and vegetables, protein, nutrition, exercise, keep your weight down. And that's really like the best that you can do. At least if you don't have access to all these other things, you know, supplements or whatnot. I have my patients running around the block while waiting for their PRP to be spun sometimes. You know?
Hello and welcome everybody. Dr. Alberto Panero here. I have the pleasure of speaking with Annette Ambach. She's a MD, a physician that I've been working with closely for several years. Recently started her own practice, BioEvolve. We're going to chat a little bit about that and get to hear all the cool things that you're doing. Today the topic is really going to be spine related, so biohacking the spine. How do we do it with Orthobiologics? We should probably note that all the stuff that we're talking about today is off-label, right?
Correct.
And we're not insinuating any indication, it's really just for educational purposes. So welcome, thank you so much for being here.
Thank you for having me.
It's such an honor and pleasure. So we're gonna get into some fun stuff. Tell us a little bit, just kind of, what's your morning routine when you have a big day of biologic injections? Kind of, how do you get ready to go for the day?
So in the morning, the first thing that I look at my schedule.
Yeah.
And basically look at all the cases that I have a plan for the day. How do we approach the treatment? How do I have my staff organized so that we are efficient throughout the day?
Sure.
And aside from that schedule, clinic schedule, I also have my tasks and goals to finish for the day.
Gotcha.
So I print out my schedule.
Sure.
And then at the bottom of that schedule, I have my things to do that I need to tick off. And throughout the day, I just want to make sure that I'm going through all those.
Nice.
Yep.
So you're all about kind of preparation, staying organized and going through it.
Yes.
All right. Well, tell us about, you know, your new practice. Kind of give us the elevator pitch. You know, what are the cool things that you're doing? I know that, you know, you have quite a bit of experience already in biologics and spine. You know, how are you taking it to the next level?
So BioEvolve San Diego Orthobiologics and Sports Center is designed to treat active people with regards to keeping their activity level, treating their musculoskeletal injury. And so our target population is the really active population. From, you know, mid-30s to, you know, we can be active at any age, right?
Sure.
And so when my patients come to the clinic, one of the main questions that I ask them is, what is your goal for treatment, right? And we want to make sure that every time they come in for the follow-up, that we're getting to that goal, whether it's like small baby steps or like where we are. So that's kind of how I practice with regards to treating my patients, because if we're not there, then I feel like we're not succeeding in our treatments.
How did you get into biologics? Everyone has like a unique story. Like for me, the first time I heard about PRP was through the Pittsburgh Steelers, Heinz Ward. I want to say it was like 2007 or 9. He had an MCL tear, and I think it was Dr. Bradley did a PRP injection, plays in the Super Bowl 2 weeks later, and I was like, oh my God, PRP is going to be
the next big thing.
What is your story? How did you get introduced to
So
biologics?
my fellowship training is orthopedic sports and spine. So I was kind of grandfathered into that training wherein you're not relegated to just sports and you're not relegated to just spine. So I was lucky enough to have both of that experience. And so I was in practice doing both, but majority spine for the first maybe 6 years. And I was just doing all traditional steroid injections, nerve blocks, you know, just our regular treatments for orthopedic conditions. And then I got really frustrated with, you know, not treating my patients the way that I want them to be. So they're coming back every 3 months and we're doing the same thing. And in 3 months, they're getting cortisone shots. So I started to just research on, you know, what other things I can do to treat them. And so I came upon, and I was practicing in San Diego at the time.
Got it.
So I came upon Steve Sampson, who's in LA, like 2 hours away. and that he's got this innovative practice. He was just starting Toby at the time.
Wow.
And so I called him up and said, hey, you know, I want to learn about this thing.
Yeah.
Can I join you guys? And like a couple of weeks later, I'm in LA.
Wow.
It was a
That's
pretty
amazing.
quick move. Yeah. So I was lucky enough to have worked with Steve for about 5 years.
Yeah.
Before I decided San Diego is better for
home.
me than LA.
Sure.
San Diego is home, and so I moved back to San Diego. But at Ortho Healing, that's where I had a really steep curve of learning.
Sure.
You know, all the regenerative treatments, met all the cool people who are doing this in and outside of the country. And it was a really, really neat experience for me.
That's
I'm
awesome.
always grateful to Steve and Ortho Healing for that.
I always think it's fascinating how much Orthobiologics has grown, how it went from like this, well, if all else fails, then you try that, to now it's like part of fellowship programs. There's specific fellowships for this. For me, I've incorporated it as kind of, I wouldn't say it's first line for everything, but a lot of times it is first line. Talk to us a little bit about your rationale, and again, we're going to focus on spine today. You know, who is let's start with intradiscal injections, which I know you're passionate about, and you've spoken on this topic several times. Who's a good intradiscal biologic patient?
So, with the spine, as you know, it's a pretty complex condition, and usually patients come in with multiple pain generators. So, to consider them for intradiscal, we kind of have to nail that diagnosis down.
Yeah.
So that's the main thing, is that we want to make sure it's discogenic pain, the images correlate, the symptoms correlate, and you don't necessarily have to do a discogram.
Got it.
You know, it could be just symptoms, MRIs that correlate. They failed all the other treatments that basically ruled out all the other possible pain generators. So if the disc is primary, then that's someone that I would consider intradiscal for.
Gotcha. Okay. So for me, you know, that means, you know, axial back pain, right? No radicular pain. Typically, it's going to be a younger patient, right, with not a lot of spondylosis. You can see like a focal annular tear, right, or maybe they had a microdiscectomy and they still have axial back pain. Those are kind of my two big ones. Would you agree with that, or are there other patients that you would include in that group?
Yeah, so annular tears, I agree.
Yeah.
The disc's height is one. You know, they have to have at least 50% disc height.
Okay.
I have done it on patients that have less than that, and I just didn't get really good outcomes. Now remember, disc pain also have referral patterns. And so it doesn't necessarily have to be axial. It could refer to the proximal thigh, to the buttock, you know, to those regions.
But are you looking that, you know, there's not a lot of foraminal narrowing or nerve compression, right? Like you can tell it's a referred pattern, not like radicular pain.
That's correct. Gotcha. Yeah, it's not your typical sciatica, you know, that you get. Now I warn patients, and radiculopathy is not necessarily an absolute contraindication to do a intradiscal procedure. I just tell my patients that it might flare you up for a few days, obviously depending on the biologic that you're injecting. But then that will go away. But if they do have a primary radicular pain with narrowing, then that's definitely not a good candidate. I'll probably do an epidural biologic first, just to kind of calm that down and quiet it down, and before moving on.
Okay. So let's talk a little bit about, we've identified our patient, right? What type of biologic do you like to use? PRP, bone marrow, micronized adipose? What's kind of your go-to?
Yeah. So there's not enough studies on adipose at the moment with regards to discs. There's one study on using SVF, but we can't do that currently in the country. Majority of the studies are on PRP and bone marrow concentrate.
Yep.
So I started my practice when I was doing the trials with predominantly just doing bone marrow concentrate.
Okay.
And then we published that RCT with Anu Navani, comparing PRP and bone marrow concentrate, and it was only a 1-year follow-up.
Yeah.
But our results were similar.
Sure.
With PRP and bone marrow concentrate. And then Greg Lutz came out with really high concentration PRP, really good outcomes, and then other data were coming out with regards to discitis with intradiscal bone marrow.
Got it.
So that's kind of when I started switching. Hey, maybe I should, consider switching and see what the results were.
Sure.
The initial results that I was seeing, comparing the two, was that bone marrow concentrate, they do get results right away.
Yeah.
Like quicker resolution of that low back pain, usually within the first 3 to 4 weeks.
Got it. Okay.
PRP just takes a longer time for me, especially if you really want to concentrate your PRP.
Yeah.
So you do have some of that WBC in there.
Sure.
It does flare them up a little bit.
Right.
Now, if you use more of the anti-inflammatory PRP, there's plus and minuses to that. Then you do get that improvement of the symptoms initial, kind of quicker too.
Yeah.
But majority of the time, it takes a longer time for me to get that response to the PRP.
Okay. And just so you guys know, the link to the study she's referring to is at the bottom. So just scroll down and click on the link so you can access the information. But yeah, the study you guys did definitely was a big change for me. One, because I know you did the PRP right, you did the bone marrow right. Correct me if I'm wrong, you guys use the MSite system for that?
Yeah.
Okay, so a solid system. How much were you injecting into the disc in your study?
Anywhere from 1 to 2 cc.
1 to 2.
Yeah,
okay.
Once you start feeling that resistance, we stop.
Yeah. So that, for me, I was always like, well, if you're injecting the disc, kind of go big or go home, do bone marrow. After your study and Lutz's study, I'm like, okay, maybe I should be considering PRP. What I've actually done sometimes too is combine both, where I'll do, I'll take 60 cc's of bone marrow, 60 cc's of blood. I'll spin it all the way down to 1 cc of PRP, combine it with 2 cc's of bone marrow, and just kind of inject both. But that's me, the art of medicine, not something that's maybe followed by a study like you guys did. What about you talked a little bit about infection? Obviously, that's the big risk. I think PRP in general terms, it's super safe in terms of it does not, you don't get infections with PRP except in the spine. Do you do antibiotic prophylaxis? Kind of what's your protocol for that?
Yeah, so I do IV and CEF.
Okay.
I think that's more to make me feel better than actually having a clinical benefit.
Sure.
And I do a little bit of gent into the discs. Yeah, very diluted.
I agree with that. Yeah, I can't remember. It might have been Chris Williams who kind of gave me the dosing. It is a little bit. You really have to dilute it down.
It's a very diluted down version of the gentamicin.
Yeah, exactly. But we do. I think I end up putting about between 0.3 and 0.5 of the diluted solution of gentamicin, and then. So my next step, I typically will put a little bit of contrast. Do you like to do contrast before you inject the biologic?
Yeah. Well, actually, I mix the antibiotic with the contrast.
Oh, nice. So that way it's
all in one.
So
that's the dilution. Yeah.
Perfect. Okay. I think there's always the question, does the contrast mess with the biologic? And I think a diluted version does not. Would you agree with that?
In a small
very
volume,
small amount.
very small amount.
Okay.
Yeah.
All right. So what, in terms of fluoroscopy versus ultrasound guidance, how do you perform the procedure? What's your go-to?
I was trained with Fluoro in the intradiscal.
Okay.
I feel that that's still the standard of care, especially with intradiscal.
Sure.
It's just very hard to do the procedure with an ultrasound.
Agreed.
There are other injections in the spine that you can perform ultrasound in.
Sure.
I just don't think discs is one of those.
Yeah, I agree. I do them all under Fluoro. I don't do cervical discs, and I know we kind of been focusing on lumbar. What are your thoughts on cervical disc? Obviously, it's it's a different beast from a technicality perspective, but what are your thoughts on it?
I think it really works well for the right patients.
Okay.
I don't do them personally. Over the years, you kind of just tailor your practice to procedures that you feel you've got the most skills on or the most benefit from. But I think it works really well for the right patients. Very smaller volumes, higher risks for sure. There's only a handful of physicians that I know in the country that does it, and I refer to them. But patients do really well.
Yeah, awesome. You know, one of the things, so I'm in private practice, we don't have IV sedation there. Sometimes patients we'll take them to the surgery center and give them sedation. So this is a very painful procedure.
Correct.
You know, the injection itself is tolerable, but it's like as soon as they get up, right? They really feel a lot of pain. You know, it's hard to get them out of the clinic. One of the things I've implemented is doing a caudal epidural, well, no steroid, just anesthetic and saline. That seems to have helped. What are your thoughts on like local or regional anesthesia? Kind of what are your protocols to help them out with it?
Yeah, I know. I agree with you. It's not a fun procedure to do for the patients. And I know physicians that does it locally in their practice without sedation. I personally do them under max sedation.
Great.
In the surgery center. I will probably start doing them in the clinic with an anesthesiologist or CRNA that can come in to do just kind of like a light awake sedation. Some physicians that I know use the MKO melts. That's a combination of midazolam, ketamine, and Phenergan.
Yeah, that's a good
it's quick. It's easy for the patients.
Sure.
But yeah, I think you need a little bit more than local for this. I still use local because we do a functional spine unit approach in treating spine conditions. Majority of the ones that I do intradiscal on, I do an epidural biologic as well.
Oh, biologic as well. Okay.
Yeah, so I do an epidural PRP.
Okay.
I have not done epidural BMAC just because there's no studies that I know of except maybe one by at Lurie that injected bone marrow into the epidural space. I filter my biologic that I inject epidurally. Okay. Just to get platelet debris and just other things that you want out. You want it clean in the spine.
Sure.
What else? And yeah, I agree with you. Once the patients get up, they feel that pain. Yeah. So with regards to protocol after, to take care of the pain, I do put them in a brace for the first few days, intermittently, not the whole time, because it does help with that pain. Less narcotics, just bracing, kind of walk around. But that helps a lot.
It helps. I, in terms of post-procedurally, I tell them, okay, expect a really, kind of your worst back pain day for a few days, even a week. Then it'll kind of start to settle. By week 2, week 3, you're kind of back a little bit to your baseline. But I'm like, don't expect any significant progress, until about 6 weeks. And it may take 3-4 months to get the full benefit, right? Not that you're going to be hurting the whole time. What are your timelines been like? Kind of what do you counsel your patients on that?
Yeah, so it's very similar to you. Okay. Definitely 2 weeks, I would say. For regular PRP, 3 to 5 days. But for intradiscal, it does take them about 10 to 14 days to get out of that initial flare. But with regards to limitation, just the first week of just taking it easy. Second week, they can start, doing a little bit more activities. With regards to pain relief, the earliest that I've seen is 1 month. 1 month, okay. These are usually the younger patients with just an isolated annular tear. You're injecting a small volume. They do get relief quicker. But it does take at least 2 months, 3 months, sometimes 6 months for patients to get that relief.
Got it. I want to touch on one last thing kind of in this area is MODIC changes. Obviously right now the big procedure is basivertebral nerve ablation for, vertebrogenic back pain. What are your thoughts on the functional unit between the end plates and the disc? And do you feel that injecting the disc, could potentially help the MODIC change, or do we have to be injecting, into the bone itself?
There is, I think, one study already on doing a subchondral biologic injection. It does make a lot of sense because we do it in the peripheral joints, targeting those MODIC changes. The approach is a little bit more involved because you have to go transpedicularly. And so you have to be really trained for it.
Sure.
So that's one limiting factor.
Sure. It's almost like a kyphoplasty
Correct.
approach.
Yeah, it's the same approach basically. And then, you know, on the other hand, some physicians would think that, hey, if there's subchondral damage, there's going to be micro fractures already in there.
Yeah.
If you inject into the discs, they will get their way.
Right.
You know, it will get.
It's going to
there.
follow
So,
path of least resistance.
exactly.
Yeah.
And so why go through another more invasive
Sure.
procedure?
Yeah, it'd be interesting. We're looking at doing a study for intraosseous injections for MODIC changes. But the more I think about it, I feel like there should be 3 arms, right? Like one is the bone alone, one is the disc alone, and then both in combination, right? And then to really see, okay, like what's the dynamic or the relationship between the end plate and the disc? Because we have an idea, but we don't know as much.
No, you're correct. And I was talking to a lot of spine surgeons about that because I was thinking the same thing, and I was trying to see what's the best approach to do it.
Sure.
And basically all the spine surgeons were telling me, well, you got to do it this way, you got to do it this way. It's kind of like we kind of need them to do those first few procedures, or they need to train us on the approach, and then we kind of need them to just make sure we do it safely.
Sure.
But yeah, to really knock out the question and answer the question, we got to do a comparative study on doing just discs with or without,
bone,
you know, a subchondral injection.
All right, so we'll conclude on the intradiscal. I just want to make sure, we want to make sure it's discogenic pain. We want to do kind of a low volume, 1 to 2 cc's of PRP or bone marrow concentrate. What's your standardization for PRP? Are you going high platelet dose, leukocyte rich, leukocyte poor? Kind of where have you been on that?
You know, my initial practice was just not getting rid of a lot of WBC because I don't want to flare them up, and just like you, I kind of want them to get some relief as well.
Sure.
So I would want to say WBC neutral, maybe a little bit high, but not too much.
Not too much, yeah.
Or if the patient's really flared up, I would just do something like a Lysate or a leukocyte poor
into the
epidurally.
Disc. Oh, epidurally, right.
And
just to get them some pain
disc,
relief.
Into the disc, if you want to get to that high concentration, you're going to have a leukocyte-rich PRP.
Sure.
So it will be leukocyte-rich, and there's some advantages to that.
Yeah, I always thought of, I agree with you, right? Trying to figure out, okay, what am I trying to accomplish, right? Is it pain relief, healing? I was always a little concerned about the infection, so I think I've been a little more towards trying to get a higher platelet dose, and I've been injecting leukocyte-rich PRP into the disc. But, you know, I can't argue against the concept of, well, they're already super flared up, like, don't, you know, throw them over the edge, right?
Correct.
Did your study was that was a leukocyte-rich PRP?
It was a leukocyte-rich,
okay, that you compared to bone marrow concentrate.
Correct.
Okay.
Now remember, if you look at that last study by Lutz on the concentration, it was 10-12 times baseline.
Yeah.
If you get to that concentration, your WBC is going to be
it's
high. So it's always going to be leukocyte-rich, which I think in the disc has got a lot of advantages.
Sure.
Yeah.
All right, well, we're going to move on to epidural injections. Obviously, traditionally, those have been cortisone-based. You can try them for, you know, kind of discogenic pain, but I believe they tend to work better for radicular pain, especially the steroid ones. You know, what are you who is the patient that you're, okay, first question, how do you determine, okay, am I doing a steroid epidural or a biologic epidural? And then are you choosing PRP or Lysate? Kind of what are you going for your biologic?
So you've nailed the first indication is radiculopathy.
Yeah.
Right? That means nerve pain coming down to the legs. However, there are several RCTs, high quality studies on using epidural PRP for discogenic pain.
Interesting.
So it does help with disc hydration as well. To the point that for those patients that do not want to undergo sedation, do not want to go intradiscal, or just don't want any needle into their discs, I do that as a first line.
Got it.
Epidural PRP.
Okay.
And it does improve. I would say at least 60% of my patients get
Improve with
really
that.
good relief with just epidural PRP, even
Okay.
if their pain is discogenic.
Okay. And do you take a interlaminar approach? Do you do bilateral transforaminal? What's your approach to try to cover the disc?
Yeah, I do transforaminal because it
Okay.
just covers the nerve root better.
Okay. And you do it on both sides?
Both sides, yeah.
Got it.
Yeah.
All right. And what's your choice? Do you like PRP? Do you like platelet lysate? Kind of what are your options?
So right now I'm doing predominantly PRP.
Okay.
We just started doing Lysate probably a few months ago.
Yeah.
We probably have about 10, 13 cases, and
Okay.
when I say we, with Dr. Chris Rogers of San Diego Orthobiologics Medical Group, we just started doing Lysate, and so far we've been seeing the results at around 3 weeks.
Sure.
So quicker than
PRP.
PRP. But predominantly right now I'm doing
PRP.
PRP epidurally. I filter it. For those patients who's got a really hot radic, I do a nanogram doses of dexamethasone.
Okay.
That kind of helps
calm it
calm it down. There's some small data on low doses, homeopathic doses of DEXA actually stimulating growth factor release.
Sure, sure.
And so it's complementary.
Right.
So sometimes I just put a little bit diluted version of that
Sure.
to the PRP.
And I know that may sound kind of counterproductive, right? But we're talking about very small doses.
Super doses.
Yeah,
Like you're talking about billionth of a gram
Yeah, exactly.
doses.
Yeah, so keep that in mind. We're not saying inject steroid and PRP at the same time.
Correct.
It's a different idea. May I ask, let's say you're doing a 1-level epidural, how much blood would you draw, and how would you try to formulate the PRP?
So if I'm doing epidural 1 level, a 60 ml blood draw will probably get me at least 7-8 times more than baseline.
Sure.
I think that would be plenty.
Yeah.
The maximum volume per foramen that I've injected is 3 cc.
3 cc's.
Yeah,
Okay.
so if they've got good foraminal size, I would
Yeah.
put the whole 3 cc as long as the
Okay.
patient is not, symptomatic
Hurting,
while
right.
I'm injecting.
Okay.
Yeah.
That's interesting. For me, I've always I've been a little hesitant to inject PRP, and I think that's just more of a personal insecurity in terms of like, okay, what if I get an adhesion or there's like intravascular uptake? But then you think about, well, like if you have a dural leak, they inject blood into the canal, right? So it may be more me than actual like hard data showing, okay, this is going to be an issue. I don't have access to the freeze-thaw method. I've been using more of what's called a platelet releasate. So what I'll do is
Dextrose?
no, I use the thrombinator,
I
which is
see.
basically like a canister with glass beads. I put the PRP into it, you shake it, and it basically activates it and clots it.
Right.
So it's kind of the same concept where you're trying to release the growth factors from the platelets into solution,
Correct.
filter it, and then
Filter.
inject that.
Yeah, that's the key.
Yeah.
So some physicians also use dextrose to activate.
Correct, yeah.
But it is more of a releasate, and you got to filter those.
Sure.
Yep.
Yeah, we actually will hopefully be publishing this data, but the method that I developed, it's equivalent to about 2 passes of freeze thaw. So I still think you might get more factors, right? If you or a higher percentage of lysis with if you do the 3 passes of the freeze thaw, but and even looking at osmotic, with like distilled water,
With a-
things like
yes,
that.
yes.
But that equipment I don't have, so I just, we all do the best with the equipment we have. But anecdotally, the results have been really good. But sometimes I wonder, do I need to, go compare it with PRP and see how it does?
Have you counted your sample with that method that
Yes.
you're using?
Yeah, the thing is, so we did 2 things. One is we just checked a CBC, and we went from a significant amount of platelets to like very little platelets. So I was like, okay, I'm lysing them, right? They're clotting and activating. But when I did a little more research, it may be that a lot of them were getting trapped in the clot. So then we took it a step further and did like an ELISA analysis of different growth factors, and we compared it to freeze thaw, and that's where we saw it was equivalent to about 2 passes. So it wasn't as good, but still pretty darn good.
Pretty good, yeah. With the freeze thaw, when we analyze our samples, we got maybe like 1 or 2 platelets in there. So we know that we're lysing them really nicely.
Right, exactly, yeah.
But you're right. I mean, you need to do what you need to do with regards to how you're going to create the perfect biologic for that patient, for that condition.
Sure.
And get as close as possible to,
what you need.
What you need.
So how do you talk to the patient about steroid versus PRP for epidural injections?
Yeah. So before I talk to my patients about their treatment, and I kind of alluded this to you at the beginning, is that I ask them, what's your goal? And if they tell me, I want pain relief now, I'm going to the Bahamas for a vacation, then that might not be the ideal time to do a regular PRP.
Sure.
Now you can, debate and say, well, you can do a Lysate and they can get relief right away. That's an option. Or put like a nanogram DEXA, that's an option.
Yeah.
But if I flare them up, then that's going to be an issue for them.
Problem.
And so I give them the options and say, look, we can do traditional steroid and give you pain relief right away, but that will delay our biologic treatment for at least a month.
Sure.
Or we can do the PRP now. There's ways that we can make it less inflammatory so it doesn't flare you up, but that can get you going at least in the healing process. And then I'll let them decide.
Well, the sun is out, so I don't want to get too off topic, but it made me think of vitamin D.
Yes.
And, what are some, we're going to close off with maybe just talking about the functional unit for Facet SI, but, what are some other things that from a general wellness or optimization that, are you looking at functional measures or looking at vitamin D supplements? Like, what are some things that you maybe try to add to your patients?
Yeah, so that's a really good question because it's a natural extension of what we do. We gotta look at the whole body. We gotta look at wellness, and if we want to optimize our treatments, we gotta make sure that our patients are primed, to have the best outcome. There's a lot out there.
There's a lot. Yeah.
There's a lot.
Let's just put it out.
Yes.
Yeah. It's almost like it could be a whole separate practice.
Correct.
Right. Yeah.
Correct. But Chris Rogers and I have been talking about this for a long time, and it always comes down to the basics.
Sure.
Right? Have good sleep, eat your fruits and vegetables, protein, nutrition, exercise, keep your weight down. Yeah. And that's really like the best that you can do. At least if you don't have access to all these other things, supplements or whatnot. I have my patients running around the block while waiting for their PRP to be spun sometimes, because activity does increase those growth factors, mobilize the stem cells. So like simple things like that
can make a big difference.
Can make a huge difference. Yeah, for sure.
All right. Well, so we talked about epidurals. Anything else? I think epidural-wise, I think we've covered it. We're pretty much sticking to PRP or Lysate. We prefer it for radicular pain, but there is evidence for discogenic pain. The difference between a steroid, again, if you have a big life event and you need just pain relief, maybe start with the steroid. And if you have some more time to recover, maybe go the PRP route.
Or Prolo. There's data to do epidural Prolo therapy, dextrose.
Okay.
Smigel did that study on caudal dextrose, giving immediate relief that can last a few weeks.
Sure.
And that, you don't have to delay your biologic for that treatment.
Got it.
Yeah.
Okay. All right. So I don't want to take too much of your time. We really appreciate you doing this, but let's just briefly talk about facet and SI pain. Mm-hmm. And I think for me, the transition was, well, steroids can be helpful. Then you have ablations. While I think ablations can be good, I think for a lot of the younger active patients I see, it's not really the best option. Obviously you're burning off the multifidi, right? When you see multiple people or multiple treatments, you get an MRI and their spine doesn't look good, right?
Correct.
So that's where I'm like, hey, biologics makes perfect sense here, right? I would agree or comment that we don't have as many studies like in NEOA for facet arthritis or SI, right? But as you commented yesterday in your lecture, there are some studies. I've been using them with pretty good success. Tell us your experience, facet SI, and then also how much ligament work do you include in those injections?
Yes. For facet, you're right. There's not a lot of studies. There's 2 high-quality studies on Biologic for the facet. You almost have to do multiple injections for facets.
Yeah.
Meaning not just one level, but the contiguous level you kind of have to inject so that you have that whole functional spine unit approach. So at least a 2-level bilateral facet joint capsule injection. I always include the interspinal ligaments, supraspinal ligaments when I'm doing facet work.
Okay.
That way you do have that whole posterior column strengthening, including the paraspinal muscles as well.
Yeah, great.
And then yes, if you're doing the SI, which if you're treating at least the L5, S1 facet, you kind of have to include the SI as well. And with the SI, it's not just a joint injection. In fact, most of the SI joint pain is probably ligamentous and instability rather than a joint problem. So you have to include all the superior, inferior, dorsal SI ligaments, the iliolumbar ligaments. You have to do, and this is where ultrasound comes in for the spine.
There you go.
We were talking of fluoroscopy a while ago, but now when you're incorporating soft tissues or even for facets, now you can do ultrasound in a lean patient. And with regards to SI joint pain, another thing that I thought of is that if they have a very unstable SI joint and they have this upslip or downslip, I even have them see the chiropractor on the day off to make that adjustment, get them in place, and then do the injection the same day.
That's a really good idea. What, obviously we talk about options. I primarily use PRP for these joints, but I don't see a problem with bone marrow. What are your choices? Are you going low dose, high dose, leukocyte rich, leukocyte poor? What are your thoughts on it?
Because it's a very small volume in the facet joint, we want a high dose PRP.
Agreed.
Leukocyte rich, high dose PRP, 0.5 to 1 cc into the joint, maybe a quarter into the capsules. Bone marrow concentrate are reserved for moderate to severe facet arthropathy.
Okay.
I use the bone marrow, younger patients. But traditionally facets, high concentration PRP work.
Yeah, I agree. I use, not that I don't use bone marrow, but PRP seems to do well. What about the ligaments? Are you do you prefer Prolo for the ligaments? Do you prefer PRP for the ligaments? What is your choice?
I do either a PPP, platelet per plasma, or a diluted version of the PRP.
Got it. Okay.
So whatever extra I have, I just kind of mix it with the PPP and then.
And here's where the art comes in, right? Because let's say someone comes in, you got to do 6 facets.
Yes.
Both SIs, the muscle, the ligament, right? This is where, again, I think a comment is, what I do is I write out all the joints I'm going to inject, and then I'm like, okay, how many platelets do I want to deliver at each joint? And then I kind of go back to, okay, if I want to get this, I need, 180, 240, whatever, however much blood, right? But that's kind of a key thing. Don't just draw the blood. And just, whatever PRP I have. No, like you really got to plan out each step.
You got to plan it. I mean, and you should see our spine tray for Biologics.
It's huge.
It's huge. It's like little, you got to basically arrange your injectates, label it, this is for facet, because otherwise it can be a little bit confusing. But this is where the planning comes in. Very, very important.
All right, well, we'll close out with some fun questions here. So number 1 is, what's one spine-related myth that you want to bust right now?
Spine-related myth?
Yeah, and I guess you can tie it to Biologics if you want, or not.
Okay. Let me think about that for a minute. What's your spine-related myth?
I think that the biggest one I see is that Biologics can fix instability. Like, let's say you have a grade 2 spondylolisthesis, right? That's shifted over, whether it's stable or not. Like, I can't bring that back with Biologics. You know what I mean? And some people are saying that, or think or advertise that, like, I can restore the alignment, like it'll heal it down and restore it, I think that's a myth, personally.
I agree. I agree with you, especially those with FARS defects.
Right.
Listhesis, yeah.
Yeah, we're good, but we're not that good.
But we're not that great, yeah.
All right, here's a good one. If your biologic technique had a theme song, what would it be?
Oh my God.
Let's see,
I
I'm
think I
thinking
need
of
more
mine too.
Celsius for
yeah.
that.
Yeah.
You go first. Let me think about mine.
Let's see.
Wait.
I don't know. It depends a lot
theme
on my
song.
mood that day. You know, sometimes I need the chill, kind of like house music that just keeps me, you know, zoned in.
Yeah.
In the surgery center, they always put Red Hot Chili Peppers. I don't know why. I love them, but they always put that in for me. But maybe that would be the theme song. How about yours?
Yeah, you know, you're right. I mean, it depends really on the mood.
Yeah.
I always like chill
Yeah.
songs like Jack Johnson or
Oh,
like
I love Jack Johnson. Yeah. Yeah.
spa music.
Sure.
Yeah, I had a patient one time. So I asked the patients too, like, what do you want to listen to? And as long as it's not country, not that I have anything against country.
Yeah.
You know, I
Sure.
play it.
Yeah, to keep them relaxed.
To keep them relaxed. And they're like, no, doc, it's up to you.
Whatever's going to make
you
you better. Yeah, for sure.
Yeah.
All right. So lastly, you know, congrats again on your new practice.
Thank you.
You know, where can people find more about what you're doing at BioEvolve? Obviously, San Diego's lucky to have you. You know, how can they contact you or reach out to you?
Yeah, so our website is www.bioevolvesports.com, or you can email us at info@bioevolvesports.com as well.
Okay.
We are in Encinitas, which is North County of San Diego, but I see patients from all over the country and outside of the country as well. So feel free to contact us for any questions with regards to your sports injuries or musculoskeletal conditions.
All right, folks. Well, there you have it. I hope you enjoyed the biohacking of the spine. Thank you so much for doing this.
Thank you. I had fun. This was fun.
Yeah, this was great. We'll see you next time.